We are ready. We can start recording, Ashwin.
First.
Everybody, welcome and happy Thanksgiving. Hope you're all having a great long weekend. I'm glad you all joined in our Alzheimer's Dementia Symposium today. Most of you know, November is Alzheimer's Awareness Month. So MVAPI, Miami Valley Area Physicians of Indian Origin, our organization took the opportunity to educate our community about this disease. For those who don't know me, I'm Jansi Koduri. I'm an oncologist and I have nothing to do with the dementia treatment. So I'm going to learn along with you all from our experts today. Alzheimer's dementia is currently considered irreversible. It causes progressive brain damage that slowly destroys memory, thinking skills, and eventually ability to carry out simplest tasks. It is named after a German psychiatrist and pathologist, Alois Alzheimer, who first described the disease in 1906. It is probably one of the most financially costly diseases. 50 million diagnosed with this disease worldwide as of now in the year 2020. The disease has been portrayed as the disease of the century. It's projected to have a near catastrophic impact on the world's healthcare system as the population ages.
Mute. Yeah, it's muted. It says mute.
Mute line होगा line है क्या?
Everybody
No,
can
it says mute.
themselves.
Unmute.
I think the host can mute everybody except the speaker.
So we muted all. So don't unmute yourself. Just stay muted unless you're speaking.
Mute करना संता है. I'm very like that.
Okay.
Yeah.
So today we are going to learn about the disease, the fear, the emotional strain, and the pain associated with the disease. Positions Alzheimer's as something that requires a remedy. Is there a remedy? We are going to learn about the symptoms, how to diagnose, and treatment strategies from our experts. And while the cause of this disease is a mystery, there is a massive research that's going on. So we are going to learn a little bit about what's coming. And the most important part, our dementia patients also feel guilt about the burden they are for their caregivers, hindering their lifestyles. And many caregivers are deeply connected with their loved ones and they feel like they have to help their family. They believe in circle of life, which means caring for each other at all ages and stages. It's their duty. That becomes very challenging. So today we also are going to have an expert talk about the support system that exists in our society to take care of our patients as well as help the caregivers. So hope you all stay tuned in and enjoy the presentation. Please send your questions throughout the presentations through the chat, and we will take upon those questions at the end of all the presentations. Dr. Vipul Patel will be helping us with the question answer session. So you can send your questions directly to myself or Dr. Vipul Patel. Dr. Patel is one of our leading physicians practicing internal medicine in Springfield, takes care of many dementia patients day to day. So he will be helping us at the end of the presentations. So we will start our program. Our first speaker is Dr. Mangala Venkatesh, who needs no introduction. Dr. Venkatesh is a well-respected expert neurologist in Dayton. I know Dr. Venkatesh since I landed in Dayton many years ago. That is since my residency training. And we will not talk about how long ago that is. All these years, I'm always amazed to see her exceptional patient care, her compassion, practicality, depth in medical knowledge, interest in teaching, and most of all, her comforting, beautiful smiling face. She's an example of great physician and an inspiration to us and a great friend. Dr. Venkatesh is a graduate of Christian Medical College, Vellore in India. She had her neurology training at Ohio State University, Columbus, have been practicing neurology in Dayton area for over 35 years. She is currently with the Premier Health Neuroscience Institute and serves as Associate Clinical Professor, Wright State University. Today's topic for Dr. Venkatesh, Alzheimer's dementia, recognizing early signs and treatment. Please welcome Dr. Mangala Venkatesh.
Thank you, Jhansi, for the wonderful introduction. Can you hear me all right?
Yes.
Okay. Hope all of you had a wonderful Thanksgiving and safe Thanksgiving, considering the circumstances. Of course, today's topic is Alzheimer's disease, and thank you all for taking time to participate in this. By definition, Alzheimer's disease is a progressive neurodegenerative disease, and it affects the cognition, which is memory, and also the day-to-day functions. Now, it's the most common type of dementia in people over age 65. I first want to point out, the question that I frequently get asked is, what is the difference between dementia and Alzheimer's? Dementia is a broad umbrella term with the same definition, where there is progressive impairment in cognition and impairment in one's ability with day-to-day activities. And Alzheimer's is the most common type of dementia. Approximately 2/3 of patients with dementia, the etiology is Alzheimer's disease. I do want to point out there are other causes of dementia. For instance, we have Lewy body dementia, frontotemporal dementia, there's dementia with Parkinson's disease. But because of the specifics, this is really the most common form in 2/3 of patients. And as Jhansi stated, there are currently about 5.4 million Americans affected with this in this country and 50 million worldwide. It's the 6th leading cause of death in the US. 1 in 3 seniors will die with Alzheimer's or another form of dementia. And the cost to the nation for the projected cost for 2020 is $305 billion. And according to the predictions, by 2050, there would be over 100 million worldwide. This I thought would be interesting, as most of our audience is of Indian origin. Currently, India has the second highest number of people with dementia. And by 2050, if it keeps rising at its current rate, India will be number 1. Currently, there are about 4 million Indians in India with this diagnosis. And by another 15 years, it's going to double. And by 2050, it'll triple in number. And really, it's going to be a big epidemic in India. And, when we all went to med school or even in this country, till the 70s, people only knew of senile and pre-senile dementia. We didn't talk about Alzheimer's disease. And the terminology became more, there was correlation. All the pathology was only described in the 80s. Some of the medications we used became available in the 90s. And most of what we know currently has only been in the last 2 or 3 decades. And the reason for the increase in dementia in India is because now there is better control of communicable diseases, there is increased awareness, and people are living longer. I want to next talk a little bit about cognitive aging. And, many people stop me, and in both patients and friends, to talk about the memory. And we know cognitive aging is the expected memory decline with age that we see in everybody. In fact, from our 30s onwards, which probably includes all of us, we begin to lose some neurons. And over 80% of people show some signs of cognitive aging throughout their lives. And the main aspects of memory that are involved would be the immediate or short-term memory and the processing speed. To give you examples, we all misplace our keys. Okay, that's normal changes of aging. Sometimes somebody, the name is at the tip of your tongue, you can't recall, and it'll come back after 10 minutes or after an hour. That's normal changes of aging. When it becomes abnormal is if you look at a key and you don't know what you're looking at, or you don't know what it does. That's abnormal. So when we talk about abnormal, so everybody can have some changes with age, but only 10% of people over 65 will go on to develop dementia, which is a fairly staggering number. And with the abnormal aging, as I mentioned earlier, there's cognitive decline that interferes with the normal day-to-day activities. And also there can be variability depending on one's culture, educational background, occupation, environment, and so on. It's not moving forward. Oh, there. Okay. Now, what are the warning signs of Alzheimer's? Not everybody will have all the symptoms at the same time. Some people may have more of one, some people may not have some of the symptoms, but some of the common symptoms, changes in recent memory, changes problem with language, communication skills. The judgment will be impaired. They can be very apathetic with loss of initiative, misplaced objects, changes in personality, and so on. I'm going to go through these slides very quickly due to lack of time. So I'm mainly going to touch on certain topics. Now, this graph shows the two big risk factors. One is age. Age is the biggest risk factor. As you see, we begin to see this in the 60s. As it goes up, it doubles every 5 years. And by the time one reaches 80s or 90s, it's a staggering number who can be affected by this. And it's much more common in women, which is the blue color, compared to the men at all age groups. So when we talk about the risk factors, as I said earlier, age is the biggest risk factor. Usually, when we say Alzheimer's disease, it's people over age 65. But there is also such a thing as young onset Alzheimer's, and that's patients who are under 65. And there are some variations in the features in their younger age. The presentation can be a little different, and we kind of evaluate them a little differently. But so I don't want you to think that it only affects the elderly. It can affect even those in the 40s and 50s. And female sex, as I said, women are more prone to it. Certain races have higher incidence, for instance, the African Americans or the Latinos, whereas the Southeast Asians have lower incidence. But then when we talk about Southeast Asians, that doesn't necessarily include the Indian race. If one has family history, that certainly increases the risk. If someone has ApoE on their chromosome, if they're heterozygous. So if they have only one gene, the risk is 3 to 4-fold, but if they are homozygous, then it increases 14-fold, fairly significant higher. If in people with Down syndrome, changes due to Alzheimer's can be seen much earlier. When they're in their 40s, they may have pre-existing cognitive problem, but they begin to decline in their 40s and they go progressively downhill, which is due to superimposed Alzheimer's, which comes on at a much earlier age. Head trauma. Now, this is possibly a non-modifiable factor, but it could also be considered a modifiable because we know we can do some things about it. You know, lately you've probably been hearing a lot about concussions, sports-related head injuries. That's what it can lead to. Repeated head injury results in what we call chronic traumatic encephalopathy, CTE. And, you know, a very obvious example was Muhammad Ali. Because of repeated head injuries, he went on to develop dementia at a much younger age. Now, when we talk about the modifiable risk factors, you know, vascular disease is by far the most common. Remember, whatever is good for the heart, whatever affects the heart will affect the brain too. So when you think of the risk factors, think of the common ones: diabetes, hypertension, hyperlipidemia, obesity. They all go together as the vascular risk factors. And of course, lifestyle factors, you know, use of tobacco, alcohol. Excess use of alcohol causes alcoholic dementia. We recommend Mediterranean diet, which is really use of lots of vegetables, fish, olive oil, or for our Indian diet, lots of vegetables and protein and less meat. Certain nutritional deficiencies are commonly associated, and we have to be careful, especially with vitamin B12, with those of us who are vegetarians. And certain other vitamins are also prone to cause dementia, like vitamin E, and so on. Educational level is actually protective. Those with a higher background, higher level of education have lesser tendency, maybe because they have greater reserves. Now, quickly, let's look at the brain pathology. On one side, you see the normal brain. This is what it looks like. And this is an Alzheimer's brain. The main feature is the shrinkage of the whole brain. And because of the shrinkage of the brain, the spaces inside which contain the spinal fluid are all enlarged. There are certain parts of the brain that are more prone to these changes. This part is called the temporal lobe. There would be shrinkage, especially in the temporal lobe, in the area called the hippocampus. And if you look at the at slices of the brain under the microscope, these are two hallmarks of Alzheimer's disease. One is what we call beta amyloid plaques. These are found outside the brain cells. These are the plaques, what you see, you know, these structures here. And then these are found inside the cells. They're called neurofibrillary tangles. The plaques are made of amyloid, and the tangles are due to breakdown of the tau protein. Now, these two were only described in the late 80s or so. But now, because of what we know, with the way science is evolving, the treatment is going to be at dealing, I mean, what can you do to prevent amyloid plaques being deposited? What can you do to prevent the tangles being formed? So most of the treatment is going to be aimed at these two. So the diagnostic criteria is memory impairment, especially with recent memory. Usually we look for something more than memory, problem with speech or language or knowing how to do things or ability to do complex tasks. And they should impair with the social or occupational functioning. These are usually for definition of Alzheimer's. It doesn't come on suddenly. Once in a while, we would have families bring their loved ones saying this came on suddenly. Something probably triggered it, but typically it comes on gradually and it has to be progressive over. Most patients have had it for 6 months or a year, or it could be 2 years, but it's progressive in time. And we have to make sure it's not due to other causes. Now, this is a very interesting slide. Now, on the vertical line, you see the cognitive decline, and horizontal is the time course. Now, the green line tells us about normal aging. With over the years, you can expect everybody to have slight changes in their cognitive function. Some people a little less, some people just a little more. That's normal aging. Now, when we deal with dementias, you can see it keeps progressing, and then this is the stage that we call definite dementia. When we see patients most of the time, they have mild or moderate. We only see patients present somewhere along the orange line. What you have to remember is there are changes occurring in the brain for a long time, as long as 10 to 20 years before the diagnosis. So this is the preclinical stage. There are changes, the plaques are being deposited, there are tangles, and the patient may sometimes have subtle symptoms, but may not know. If we really had to measure the biomarkers in the brain with the amyloid and tau, they are present already. But the patient doesn't know. You can do any neuropsychological testing, any other test, nothing would pick it up. So changes have been happening in the brain for 10 to 20 years before there are actual changes. Then there's a phase that we call MCI, mild cognitive impairment. This is a phase where the patient is aware of changes in the memory. Sometimes the family members or close, colleagues may notice certain changes, but the person can continue to function normally. They can drive, they can continue to work, they can do all the activities. It doesn't interfere with the function. So we call it mild cognitive impairment. And the reason it's important to follow these patients is because about 10% will gradually develop. Some people will remain as mild cognitive impairment, but about 10% will progress to dementia every year. And if we continue to follow them, about 50% of them will have evolved into definite dementia in about 5 years. And then we come into, once you develop dementia, it's a downhill course. And, for ease of discussion, it's kind of classified into the different phases: mild, moderate, severe. And the timeline for this can be anywhere from 5 to 10 years. There are patients who can even survive for 20 years. It's not dementia that kills the patient, it's the indirect complications. And so again, as I said earlier, you can have mild, moderate, or severe. And the features are typically in the early stages: problem with memory, forgetfulness, they'd be apathetic, would appear somewhat depressed, mood swings. And a lot of times patients may be aware of it, they get frustrated, they get depressed because they realize they're not able to do things like they could do before. When they get into the moderate stage, they have more problem, more difficulty with the memory, they can't learn new things, more forgetful, more personality changes. This is when we begin to see more behavioral issues. Dr. Patel will discuss about how we deal with all the behavioral issues. And this is when they begin to need some more supervision with their day-to-day activities. And then as we advance into the more severe stages, by then they really have no awareness of what's going on. They have problem with the speech. They don't know. If you show them a toothbrush, they don't know what it is. If you hand them their clothes, they don't know how to dress themselves. There's often incontinence. They have difficulty walking. They can't take care of themselves, and they may need total care. So when I talk to patients at different stages, I tell them this is like you're going from taking care of a 9 or 10-year-old. In a few years, you'll have to spend time with them, take care of them like a 5-year-old, and eventually they get to a 1-year-old where they need total care. So how do we diagnose? The most important would be history. We like to get the history both from the patient and family members. That's most important because a lot of times patients are not aware of all the problems. It's someone who knows them well. They would be able to provide the history. We look at the risk factors. Do they have vascular risk factors? Are they on, most importantly, are they on medication? There are a lot of medications that affect memory. Medications used for bladder problems, medications used for depression, medications, for instance, that we use in neurology for seizures. They can all cause memory issues. And then a quick office testing would be doing the mini mental status or MOCA to assess the memory, routinely blood work, and neuroimaging to look at any structural abnormality in the brain. We usually like to either get CAT scan or MRI of the brain. MRI is preferred to make sure that we're not missing something else. And in some cases, especially in those patients who present with MCI, We like to do neuropsychological evaluation where they put patients through more elaborate tests. What I tell patients is there is no single test to diagnose Alzheimer's or dementia at the present time with our routine testing. Depending if there are some atypical features, we may consider doing lumbar puncture and obtain spinal fluid testing, EEG, PET scan, and so on. In terms of medications, as I said, whatever medication we have available currently, the first set cholinesterase inhibitors were approved in the 90s. The NMDA receptor antagonist, memantine, was approved in 2004. We have not had any other medicine approved for Alzheimer's disease since 2004. Despite, and that's where, and the medications that we have now, it's not going to reverse the changes. It's not going to stop the progression. These are of modest benefit. All they do is kind of tilt the curve a little bit, so the progression is a little slower than it would be without the medication. So we have to teach families to be realistic with their expectations. And all these medications, you could choose any one of the three. I mean, we don't combine them because they all work by the same mechanism, and they're all available as once a day or twice a day. And Exelon is also, rivastigmine is also available as a patch. And on the whole, the side effects are typically GI side effects with nausea, vomiting, diarrhea. And when they get into, this can be started in the early stages itself, in the mild stages. When they get to a little more moderate stage, we often add memantine, and because the combination is said to work better than the first category alone. And I know what's going on in everybody's mind. Can we take supplements to prevent getting dementia? And you see ads on TV every day. You hear about Prevagen, you hear about fish oil. Ginkgo biloba was very popular about a decade ago. Something we all have in our diet. We add we add turmeric or haldi, and the chemical is curcumin, which is said to be of beneficial effects. So, and coenzyme Q10. So, and there are numerous others, but we have to be careful. We don't know. These have been, there is probably definite benefit from some of these, but they have not been studied adequately in terms of efficacy and side effects. We don't know about the purity of some of these depending on the manufacturer. And thirdly, we don't know if these would, whatever supplement someone takes, if it would interact with any prescription medication. For instance, Ginkgo biloba was used quite a bit a decade or two ago. Even now patients use it, but patients who take blood thinners like Coumadin or any other blood thinner have to be careful because the two medications can interact. So finally, when we talk about treatment, I talked about medication, which is of modest benefit. We have to control the risk factors. We stress on social contact and recreation in terms of keeping up with activities. But and of course, patients, we stress on importance that they should be able to hear well and see well. If they don't hear or see well, they're not going to register, and that's going to aggravate the dementia. And most important, caregiver. This is a disorder that affects, there are two victims. It's not just the patient, but it's the caregiver too. And as they get more and more advanced, most of the discussions are because, to relieve caregiver stress, to address their questions. The patient is oblivious to many of the problems as they get more and more progressive. And finally, this is a multidisciplinary approach. We need to get help from the therapists. Counseling is needed. You want to maintain their dignity. A problem that often comes up is driving. When do we tell them to stop driving? And then we have to educate the caregiver about whatever's at different phases, what's going on, what's expected. And while the patient is still able to make decisions, they have to try to decide about end-of-life decisions and then the palliative care. And finally, what can we all do to reduce our risk of getting Alzheimer's? We know, it's going to be a big epidemic. So what we tell patients, keep your brain, brain exercises, keep your brain active. It doesn't have to be, if someone is not math oriented, they don't have to do Sudoku. You don't want someone to do something that's challenging or frustrating, whatever interests the person. Keep your mind active with the brain exercises, physical activity. Again, whatever is appealing to the person, whether it's aerobic exercise or swimming or walking or Tai Chi or dancing, any of that would be great. Healthy diet. What's good for the heart is good for the brain. So watch the diet. Stress reduction, it could be in the form of yoga or meditation or whatever appeals to the person. Maintain your social network. Be stressed not to sit on this couch and watch TV all the time. Keep connected. I think Indians in general are very socially connected. I think that's a very positive aspect. Have a positive look, have a purpose in life. And you can manage the environment by modifying what you eat, minimizing smoking, minimizing alcohol, watching the diet. And then finally, the individualized care plans. This is what's we're going to see in the next decade. We'll talk about brain health. There is no test to check for brain health. If brain has symptoms, that's how you know there's something wrong with the brain. So we don't do any routine testing on the brain. But what will happen if someone has a strong family history of Alzheimer's and we see them, they can be in the 40s. If they're going to be at risk, we'll be getting to the stage where with the biomarker testing of the blood or spinal fluid, we can identify individuals much earlier. And then we can tailor the treatment plan. So hopefully in the next decade or two, we're going to see a lot of changes with the treatment. So you can stop it. Even if you can delay the onset of Alzheimer's from 65 to 75, we have accomplished a lot. So that's what we hope to see in the next decade. And in conclusion, remember, you are what you are because of your brain. So protect your brain. Thank you for your attention. And I think we'll address the questions at the end of the session.
Thank you so much. That's a wonderful presentation, Dr. Venkatesh. Thank you so much. Yeah, Alzheimer's is impartial. All genders, any region, any race, you can get it. So if there are any preventive strategies that we could be educated on, that's great. Dr. Vipul Patel will be introducing our next speaker.
Our next speaker is Dr. Amita Patel. It is my privilege to introduce Dr. Patel. She's a board-certified medical director and has a Master of Science in Health Administration. She's a director at Behavioral Services at Wayne Healthcare and Joint Township Hospital in St. Mary's Hospital, Ohio. She also directs one behavioral health unit in a nursing facility in Dayton, Ohio. Dr. Patel is a diplomat of American Board of Psychiatry and Neurology. She is also board certified in geriatric psychiatry and clinical psychopharmacology. She is a leading clinician and educator of geriatric psychiatry. She is a member of numerous professional organizations and associations, such as American Association of Geriatric Psychiatry, to which she has awarded Distinguished Fellow. The American Medical Directors Association and American Psychiatric Association, to which she was elected a Distinguished Fellow. She has been recipient of several awards, including the Clinician of the Year Award in 2005 from American Association of Geriatric Psychiatry. In addition to patient care, research, and teaching, she serves on numerous committees and boards. Dr. Patel received her medical degree from University of Bombay, India, and did her psychiatry training from University of Cincinnati, Ohio. Here is Dr. Amita Patel.
Thank you for that kind introduction, and thank you all for joining us for this lovely presentation on Alzheimer's dementia and treatment. I hope you all had a wonderful Thanksgiving weekend. My topic is to talk about challenges with behaviors and management of Alzheimer's dementia. Dr. Venkatesh talked about diagnosing Alzheimer's dementia. What I'm going to be talking about is what she talked about is what the behaviors occur. So our objectives are to describe the behaviors, and the other terms for these behaviors are what we call neuropsychiatric symptoms or BPSD, which is behaviors and psychiatric symptoms in dementia, and talk about how we diagnose them and how we treat them. So the neuropsychiatric symptoms or the behaviors that occur in patients with Alzheimer's dementia are very, very common. The estimated prevalence of these are 80% of patients with Alzheimer's dementia. They also occur in mild cognitive impairment, as she described. Prior to Alzheimer's dementia, patients have a stage called mild cognitive impairment, where patients are sometimes aware of what cognitive deficits they have, but are able to function in society. This is about 30 or 40 months prior to the diagnosis of early dementia. So the neurocognitive symptoms that are generally seen in this stage are changes in their sleep pattern, social withdrawal, depression. Sometimes even because they are aware of the cognitive loss, they can get suicidal. So these are some of the common. Some people even get paranoid and suspicious. And the prevalence of these symptoms generally increase as patients age, they progress into the Alzheimer's dementia. And these symptoms continue to change as patients progress into various stages of dementia. The mild behavioral impairment in the MCI stage, it is possible that the neuropsychiatric symptoms or the behavioral symptoms even precede the onset. And these symptoms, if they are occurring, then we can say that this is sort of a prodromal stage that is associated with increased rate of patients. If they are having, like Dr. Venkatesh talked about, how patients with MCI, 10% of those will convert every year into Alzheimer's dementia. But if patients that are having neuropsychiatric symptoms or any of these behaviors, they are more likely to be converting into Alzheimer's dementia. So this is, again, another way of identifying those high-risk patients and catching them before they tend to progress. So we need to establish which are those neuropsychiatric symptoms, which and make that exact correlation, which actually are at high risk. So far, the studies that I've done have actually shown that apathy, social withdrawal, paranoia, changes in the sleep, depression, and these are highly correlated with later on progression into dementia. And if you look at the time frame, it's generally about 22 to 30 months before all these symptoms start to occur prior to the diagnosis that is made. What is the prevalence in the nursing home? We know that we have about 16,000 nursing homes and about 22,000 assisted living facilities in this country. So the prevalence of patients who have cognitive impairment with some type of memory problem is about 70% of those nursing home residents. And we know that a lot of those have diagnosis of dementia. So 90% of these patients will have at least one form of some disruptive behavior. And 45% of these will have 4 different types of disruptive behavior. So for example, what are these disruptive behaviors? They can have changes in their sleep, depression, agitation, aggression, exit-seeking behavior, changes in their eating habits, difficulty with compliance. So these are the various types of behaviors they can have. Apathy, no motivation, so difficulty with ambulation, frequent falls, impulsivity. These are very, very common types of behaviors that we see. These behaviors are chronic, so we can't say, let's ignore it, it's just happening today, and it's going to go away. Unfortunately not. These are chronic, and it can change from day to day, depending on the circumstances or the mood. And it can fluctuate depending on how the patient is doing or what the circumstances are from day to day. So what are some of the common types of behaviors and the prevalence of it? Anxiety. So why does anxiety occur? Anxiety occurs in these patients because they have trouble figuring it out, how to cope with, because of their cognitive or memory difficulties. They have trouble coping with, they cannot occupy their time. They don't know how to do things. So sometimes it makes them more anxious. Apathy is a extreme form of social withdrawal that they have, and it's 48 to 92%. It's again because they do not have the ability to sometimes do things. Nothing interests them because they can't figure out things. Delusional. So most common type of delusions they have is somebody's trying to hurt them, somebody's trying to poison them, somebody is stealing from them, somebody is trying to abuse them, or doing purposely negative things for them or towards them. Depression is quite common. Disinhibition and impulsivity. So sometimes when you're trying to help them, they actually try to hit at you. Impulsive. So if they're a fall risk, they'll try to get up and still try to walk by themselves and they will fall. Impulsively trying to say nasty things, or impulsively trying to touch inappropriately. Hallucinations, they actually see animals, shadows, people, bugs. They might feel bugs crawling on them. Inappropriate sexual behavior, not uncommon, touching or saying nasty things. Mood lability. So they might be a minute happy, another minute they might be very angry or irritable. Sleep disturbance, because they cannot occupy their time. So they nap a lot during the day and they have trouble sleeping at night. They might go to bed early and then wake up frequently. Stereotyped behavior. So what do? They do what we call shadowing. So if they find an adult, they will continue to follow them because they are scared to be alone. Or sometimes they have stereotypic behavior of banging something or picking at their fingers, or weight loss is very common because they don't like food, there's changes in taste, and they don't know how to feed themselves. They might play with food, they don't know how to use utensil. So how do we assess the patients who are having behavior and psychiatric symptoms related to dementia? How do you do an assessment? So the etiology we know is biological. Dr. Venkatesh talked about the genetic factors and of course the psychological factors I talked about. So for assessment, you want to do the medical assessment to make sure that it's not related to something else. So we want to rule out, say, patient has, it's not related to patient is constipated. That's why they are, because they can't verbalize that they have a stomach upset or they have a urinary tract infection. Psychiatric, we want to make sure that it's not underlying depression, or they have true fear that somebody is not actually abusing them and that's why they are scared, or they don't have a post-traumatic stress disorder, or it's not a medication side effect, that it's not related to any of the medication causing the side effect. Most commonly, this could be benzodiazepine medication, corticosteroid medication, a bladder medication, or it's because of that it's only related to their memory problems, function, or it's a premorbid personality. It's just their personality to be not so social or friendly, or it's their personality to be very short or irritable. So we need to know what their personality is like. Then do a physical exam, neurological exam, blood test, do vitamin levels to make sure, even neuroimaging, what Dr. Venkatesh talked about, like an MRI or a CAT scan if needed. Do scales to make sure what level of dementia they're at, so you know at what intervention level you can do, whether you can really work with them. Because if it's at severe level, they really do not have the cognitive ability, so you will have to really do all the behavioral intervention, mainly at their level, because they have no memory to remember. And of course, if it's a drug effect, you may have to remove the offending drug. And then the management, Recognition is the first thing. So you want to make sure that this is not related to any medication or psychiatric disorder. If it's related to medication or medical illness, you want to treat that first, or remove the medication. If it's a psychiatric illness, you want to treat the psychiatric illness. Always treatment should be individualized. And of course, reverse the aggravating factors and adapt to the specific cognitive deficit. If it's mild cognitive impairment, it's easy to work with the patient versus if it's a moderately severe or severe stage of dementia. And acknowledge patients' relevant losses and stressor. Just imagine when you are at that level where you can't even figure out what a toothbrush is or how to dress yourself. It's very, very frustrating for a patient when they can't really tell you that they're having constipation or they're having aches and pains. They cannot describe, they cannot hold a spoon and can't feed themselves. That's at some level, sometimes they recognize it and it's very frustrating for them. So we have to be very empathetic and go to their level and be able to help them at their level. And educate the caregivers, because caregivers are also under a lot of stress, having to give care 24/7 to a patient or a loved one who is giving the care all the time, and they are taking that kind of stress. I call the caregivers actually hidden patients, because it's been shown that the caregivers also go through 50% of them have some form of mild depression, sometimes anxiety. They have high risk of diabetes, hypertension, and other diseases like hyperlipidemia because they do not have time to take care of themselves. So if you are one of the caregivers, you need to take time to take care of you so you can be a better caregiver. Other behavior management concepts, when you are giving care to a dementia patient, you have to recognize that they do not have the cognitive ability to take a 3-stage command. So when you are dealing with them, you have to keep your request very, very simple, single stage command. Avoid very complex tasks, because when you give them very complex tasks, it creates more frustration. That will create more agitation and more behaviors. Avoid confrontation. So if they are saying that, no, I remember it this way, or this never happened, or you're stealing from me, or you stole my purse, I would say, maybe we misplaced it somewhere. Let me help you find it. I would pretend to help them find it rather than saying, I did not steal your purse, and get into an argument with them. And later on we say, oh, I was not able to find it. How about let's go have lunch now, and distract them, and then find that purse and give it to them. Don't get into an argument. So pretend like you're trying to find them, distract them, hopefully they'll forget, and then find it and give it to them. So do not get into an argument. Remain calm, firm, and supportive so that the patient doesn't become upset. Being consistent with avoiding unnecessary change. So if they are living in this household, in this bedroom, try not to change that bedroom, because they orient themselves with their environment. So changing homes, changing state, changing cities, changing place is very, very disorienting for the patient, because the orientation clues are very good. So if they can't find their room, sometimes they can read stuff. So you're putting a big sign, grandma's bedroom or bathroom, put a picture of a potty at the door. So they will know where the bathroom is. So they will know where their room is. It's a simple explanation like that, or put grandma's picture on the door so they know that this is my bedroom. So recognize decline in the capacity and adjust the expectation. So you'll have to change your intervention as the disease progresses, as the symptoms change. So when the behavior occurs, say when a big episode of agitation occurs, how do you assess that what happened? Why did it happen? So say, for example, it's 5 o'clock and it's dinner time, and you called grandma to come and have dinner with you. And rather than coming out and coming for a dinner, she starts throwing things and whacks a cane around and threatens to hurt you and says, I'm going to leave, and starts going to the door, and she's not even appropriately dressed for the winter and tries to go leave. You just have to think what just happened before that behavior. So what happened just before that behavior was that grandma had asked for something to be done in her room, which was her bed to be made certain way, and it was not made to her satisfaction. So what was the person doing? She was thinking, because it got dark early in the winter, she thought it was time for bed, and she wanted her bed made certain way, so she could go to bed. What was happening? It was not made to her satisfaction. And who was present? Somebody was present who didn't meet her needs, and the consequences was the behavior. So recognizing what behavior is very, very important. So sundowning. So when it gets dark in the evening, this kind of behavior can happen. And the trigger was in grandma's mind, there's certain things, certain way it had needed to happen. It didn't happen. And you were asking her to change her whole routine. In her mind, she wanted to go to bed, and now you're asking her to come to dinner. And that just made her mad. So recognizing what happened is very, very important to understand, so it doesn't keep on happening again and again. So cognitive impairment does lead to losses of pleasant activities. So they can't find pleasure in things. So it is our job, caregiver's job. Anybody is a caregiver. Any interaction should be a pleasant interaction. So it leads to loss of pleasant activities. So decrease in pleasant event can really lead to that boredom and behavior problems and depression and worsening of that apathy. So caregivers can identify and implement pleasant event for the person with dementia. Any interaction, anything you do with that patient, with that person, should be pleasurable in that person's life, in that person's moment. So every interaction has a potential to be a pleasant event. Pleasant event is everyone's job. So let me give you an example. So you can walk into grandma's room and say, Grandma, can I open the shades for you? Look at that. What a pretty day outside. Or look at those trees. Don't they look pretty? And oh, that purple looks just wonderful on you. You can go with a big smile and start the day like that. So just the simple interaction, rather than saying, it's time for you to wake up and come for breakfast. You can just start the day by even saying pleasant things and make it a pleasant day. So that big smile, that positive voice, that positive interaction, everything you say positive starts off the day positive. So the cognitive symptoms you cannot reverse, unfortunately, is complex attention, executive function, learning, memory, language. But the things you can change, the behaviors you can change, of course, you can treat the depression, the psychosis, when they have the paranoia, when they have the hallucinations, when they have the severe agitation, aggression, when they have the sleep disturbance. You know, good night's sleep, we all appreciate our good night's sleep. So you can give them something mild like melatonin. You can teach them better sleeping, keep them awake during the day so they sleep better at night, keep them active. So all these other things can be helped to give them better quality of life. So we have two options. We can do pharmacological treatment or non-pharmacological treatment. We should always prefer to do non-pharmacological treatment first before we pick a medication. Certainly, non-pharmacological intervention. You should never reach out for a pill when patient is just wandering, because they cannot keep themselves busy reading, because they have no interest in it. They can't understand it. They've lost interest. So they're wandering. They're restless, fidgety, uncooperative. Sometimes they are sad and crying because they get frustrated because they can't remember things. They can't figure out things. They can't do things for themselves. Poor self-care. Sometimes they layer clothes. They mismatch clothes. They're forgetful. unable to pay attention, repetitive. So they'll ask the same things again and again because they forgot, or they'll tell you the same story again and again. Refusing care, sundowning, more behaviors when the sun goes down, or shadowing, following you around. For these behaviors, you should always try behavior intervention of some form rather than using medication. Never use medication for this. So the behavior intervention that we always do is called the DICE approach. So describe the behavior, investigate what causes the behavior, create, so make a plan, and then implement the plan and evaluate if your intervention is working or not. So ask the caregiver for recording the behavior, elicit the distress behavior, environmental consideration, when, where, like I gave you an example how it happens. And is it related to medicine, pain, medical condition, psychiatric symptoms, bored, failure, of loss of control, cultural factors, depression, poor sleep? And then create a plan. It has to be an individualized plan for each patient, and have a strategic behavior intervention. What are we going to do? And respond to the physical problems. Of course, if it's related to pain, you're going to treat the pain. If it's related to sleep, you're going to treat the sleep. If it's related to frustration, you're going to figure out what causes the frustration and minimize that risk. If it's related to medication, you're going to take away the medication so that it's not causing the side effect. If it's related to depression, you're going to treat the depression. If it's related to, say, other things, then you're going to figure out what's causing sundowning or shadowing, fearful. Then you're going to give them that comfort level so that they don't do that. So, and when you do the intervention, you have to look at whether the intervention was implemented. Was it effective? What were the unintended consequences? If not implemented, why? Then look at the target behaviors. Did it work? Did the behaviors go down? And if not, then we have to use the medication. If you're using the medication, then you have to look at the efficacy of the medication, side effect, and if they had involuntary movements or fall because of the medication. And of course, you got to check with everybody. If you're looking at the medication, then you have to look at medication as a symptom complex, because there is not a single medication that's FDA approved for management of behavior problems, behavior and psychiatric symptoms of dementia. So you've got to look at medications as a trial and error. If there's an urgency to treat the behavior that are really, really severe, you may have to use antipsychotic or benzodiazepine. Sometimes patients also need inpatient psychiatric treatment. But you have to look at behaviors as a metaphor if you have to use the medication. So if patient is depressed and that's causing the behavior, we use antidepressant. If patient is more manic and agitated and really restless, we use mood stabilizers. And if patient is really psychotic and that's causing the behaviors due to paranoia, hallucinations, and delusional thinking that's causing the behavior, then we use antipsychotic, but very cautiously because of the black box warning of these medications in patients with dementia. I'll stop here and take questions. Thank you for giving me this opportunity. Appreciate it.
That is excellent presentation, Amita. Thank you so much. It's a fearful disease. You know, a lot of us are scared of and don't know what to expect, what to do. Your explanation is just great. We will move on to the next speaker, Dr. Meenakshi Patel, and Dr. Vipul Patel will introduce.
Again, it's my privilege to introduce Dr. Meenakshi Patel. Dr. Patel is Associate Professor at Wright State University in Dayton. She's a practicing at Valley Medical Primary Care as well as Principal Investigator at Valley Medical Research Center. She's a medical director at several nursing homes where she is taking care of many Alzheimer's dementia patients. She has earned her medical degree from University of Bombay in Bombay, India. She completed her residency in internal medicine from Sinai Hospital in Baltimore, Maryland. She's a board certified in internal medicine, geriatric, hospice, and palliative care. Here is Dr. Patel.
Thank you so much, everyone, for joining us. I'm so excited to have had the opportunity to get Dr. Venkatesh and Dr. Amita Patel to present on the disease state and treatment of the behaviors, which really is one of the biggest challenges, and which is what drives admission to nursing facilities, because families cannot manage the behaviors. Dr. Venkatesh said very correctly that we have not had any treatment approved after 2003 for the treatment of Alzheimer's. This is not due to lack of effort, because every single pharmaceutical company has tried to develop therapies for Alzheimer's dementia, but it just shows you how difficult this whole disease state is, not only in terms of treatment, but also in terms of diagnosis. How do we diagnose it accurately? How do we measure change in terms of benefit? That's really what the challenge is. And so the pipeline showed us 112 agents in 2018 in phase 1, 2, and 3 clinical trials. Okay, 112 agents, and still we have nothing to show for it. So 63, or 2/3 of them, were called disease modifying agents. And what does that mean? What that means is we're trying to impact the disease itself. What treatments we have available right now are those that actually just tweak the disease a little bit, slow down the progression, but really don't change the disease itself too much. And so we're trying to see if we can actually modify the disease with these therapies. And then about 1/4 were tested for the ability to enhance cognition, which is what we have right now. And about 10% were to treat behavioral symptoms, because as Dr. Amita said, we don't actually have any treatment available to us specifically for the treatment of behaviors in Alzheimer's. And we've kind of used treatments that we use in other disease states to manage the Alzheimer's disease here. And I just am going to show you a few pictorials just to show you what they're looking at in terms of the brain itself. I'm going to skip this one because we do have to, we're kind of running short. But here are the proteins, the amyloid plaques and the tau protein. Those two are the areas of focus for research. And this is what happens, inflammation. And so we're also looking at anti-inflammatory drugs. We're looking at diabetic drugs in the treatment of Alzheimer's. So we have all kinds of studies going on in this arena. Here is a normal brain. This is an Alzheimer's brain. And so with imaging, we are now able to see and make a diagnosis more clearly than just with a history and physical exam in terms of Alzheimer's dementia. So there was a lot of research also being done with radio imaging tracers to help us identify the disease better. So these are a group of drugs. They're called BACE inhibitors. And what they do is they target enzymes that cleave the amyloid protein and reduce the formation of beta amyloid. They're also trying to get rid of beta amyloid in the brain. And there have been multiple agents that we have trialed. I have been part of some of this research as well. But unfortunately, nothing has come to fruition yet. We also have agents that are targeting tau protein. And there are 7 tau immunotherapies that are now in clinical trials. So the biggest thing with research is that we do have disease-modifying targeting tau protein antibodies as well. I think what was in the news most recently was the Biogen agent, which was a monoclonal antibody. And they had one positive study, and they had gone to the FDA for approval, but FDA has asked for one more trial with that agent before they want to approve it. So I think it's with the lawyers right now. Behavioral symptoms, there have been mood stabilizers that are being repurposed, NMDA receptors, and the new classes of agents that are being studied to help with behaviors in Alzheimer's. And again, nothing has been approved yet. We have imaging, and that actually has been the biggest breakthrough. We have actually been able to find radio imaging agents to help us identify amyloid burden and tau burden in Alzheimer's dementia. So we can more definitively make that diagnosis. However, these are very expensive and not always covered by insurance companies. Dr. Venkatesh mentioned the CSF tau protein, which does help to identify Alzheimer's in the earlier stage, and that's done by a lumbar puncture through the spine. What can we do? So if you or your family member or somebody you know has earlier Alzheimer's dementia, please learn about new trials and participate where you can, because the more we participate, the closer we will get to being able to find an agent that will help us to manage this condition. Additionally, I wanted to talk a little bit about when you develop dementia, there are 3 very important things to do. One is to prepare a living will if you already haven't prepared one. Identify a durable power of attorney for healthcare, and that may not be your spouse. Just identify someone who will know what it is that you want. When I started practice a while ago, 30 some years ago, we had so many people with G tubes, tubes in their stomach to feed them, because nobody had any advanced directives. And I think that's probably one of the worst outcomes for end-stage dementia. You don't want people to be artificially fed. So if you can make these documents ahead of time, that will help to drive your care. And then the DNR form. So people think that if you have a living will and you have a durable power of attorney, that you automatically have a DNR form, and that is not the case. So there is a specific DNR form in Ohio, and that's what needs to be filled out to make sure that your wishes are met. So I'm going to stop there, and let me see. And I want to go ahead and introduce the next speaker. It's a pleasure for me to introduce Eric Van Blyman. I have known him for many years as he serves in the Alzheimer's Association in Dayton, Ohio. So he currently serves as the regional leader for Ohio, Michigan, and West Virginia at the Alzheimer's Association, and has been with the organization for the last 18 years. His work with the association started as a program director, leading professional education, support groups, and family training for the association, formerly a long-term care ombudsman in Indiana and a manager of independent living and adult daycare at an Ohio retirement community. His career has focused on helping families navigate the impact of aging and dementia. We all know this is a very, very difficult illness for both the patients as well as the caregivers. I think more so for the caregivers than the patients themselves. And Eric is going to be a world of knowledge to tell us about what resources we have in our community that we can access. So welcome, Eric.
Thank you, Dr. Patel, and thank you for having me on today. I'm really glad to be with everyone. Let's see if we can apologize.
You were sure. You were okay.
Oh, did you see it?
Yeah, you could see it.
Okay, you see that program?
Yeah, yeah, absolutely.
Sorry, it didn't come up on my screen. So,
Yeah.
well, thanks again for having me. So, a few weeks ago, one of my friends called. It was, I don't know, 8, 9 o'clock at night, and his dad went into the hospital. He was a caregiver for, his dad was the caregiver for his mom who had Alzheimer's. And frankly, the caregiving got to him. And, Dr. Patel talked about this with the behaviors, Dr. Venkatesh as well. And the care for the caregiver became so overwhelming, they ended up sick and in the hospital. And so much of what we try to do is help on the caregiving side. We do the research side too, but for today, on the caregiving side, it's really focused on what can we do to help the 15 million Americans really across the country who are dealing with this day in, day out, 24/7 as it progresses. In the early stages, you don't always recognize it, so they think it's maybe normal aging, and they have that confusion. And so we have set up services for them or connect them to services in the community. And so let me go here real quick, just our vision. I want to mention this, and we recently, just before the pandemic all broke out, had released our new vision and mission. And it will look similar if you're familiar with it, in that it's a world without Alzheimer's. But we've added both in our vision and our mission all other dementia. And so many families felt like they couldn't come and talk to us, or even physicians felt like maybe they couldn't refer to us because it was only Alzheimer's. And so we added that in to make sure that people understand in our vision and mission that we're very interested not just in Alzheimer's, really servicing, particularly on the service side, any dementia that families are dealing with. I'm going to break this up, spend most of my time on caregiver support. I want to touch on improving systems, which is more new work that we're beginning to do. But talk about what, if you're seeing somebody, whether it's in your family, in your network, or in the office, a patient that's dealing with this, what can be done to help them. So I broke this down into group service and online. We'll talk about one-on-one. And so we have support groups. During COVID right now, everything meets either virtually or by phone. And so a lot of our groups have adapted to that because they need that support and care. And this is such a fantastic service for somebody because of this disease progresses over so much time. I mean, families could be dealing with this for anywhere between 5 to 10, even up to 15 years. And as they do, it progresses, it continually worsens over time. And so families are really trying to figure out what's next, what do I need to do, what service do I need? And the support group is an amazing place for caregivers to come learn from others. A lot of times they'll kind of push on each other too, to accept what they're dealing with, to find different resources, but we continue to see those as essential in terms of our service. We do education programming. And so, when the caregiver gets the first diagnosis and they hear it with the person, a lot of times they're just in shock. You might even share with them a few things, but their brains just kind of shut down and they begin having to deal and cope with that. And then over time, they start facing, Dr. Patel talked through all the behaviors. They start facing all of these different issues and they're stuck. They need to understand the disease. They need to understand what behaviors are, how to communicate. They need to understand how to work with their physician and all those things. And so we have education programming set up for them on all of those topics. Anything from just awareness and the 10 warning signs that we do out in the community to behaviors, end of life, all of those things, because they're so essential to helping families. And I have watched families go through these trainings. I've been a part of this for almost 20 years now. And I've watched them when they begin to understand that this is a disease, that their mom's not just doing that there's things that they can learn to do to make their lives better for both them and the person with dementia. And so I've watched this type of education programming really help and change people's lives. Online, you guys get that. You can see, and I added a couple of resources that families might be able to access online. One is a community resource finder. So if they're looking for resources, adult daycare, home care, nursing care, etc., those all could be found online through that, as well as tons of resources for the families. And we get a lot of good feedback on that. I'd like to talk about two things. One is one-on-one care. We do run a 24/7 helpline. Saturdays, when all this are harder to get to, but families are dealing with this, maybe they're home from work from the week, or Saturday nights, during the week, Tuesday, it doesn't matter. 24/7, we're here to help families. And we help hundreds of thousands of families per year. And we can do a couple of things. We can do information referral. They might just call and say, hey, I want to know a support group and how can I, get connected? Or they might call and say, I don't know what to do next. I'm overwhelmed. I don't know how to go through that. And that's what we call a care consultation. And that's really where we listen to the issue, and we'll spend sometimes an hour, even more, with the family to listen to what's going on, to understand. We try to take time to see where they're at in the disease process. Have they been diagnosed or haven't they? If they have, what support systems have been put in place, et cetera. And so we work with the family in any way that we can to understand what the core needs are of that family, of the caregiver and the person with the disease. And then we begin to link them to resources, to education and support, as I've shared before, to maybe go see a physician, to go back for a second opinion, whatever the need is that they present. And this is where we watch real change happen in a lot of our caregivers. And when we had our office open before COVID, and I would still see people walk in the doors and just, they have this kind of blank stare. They don't know what to do. And you sit down with them and you begin to help walk through, where are you at in the disease, helping some basic education, and then start guiding them and giving them a plan. That is where they really can begin to grab hold and be empowered to make the changes they need to help walk through this disease. And so absolutely essential in terms of our ability. We have done them one-on-one and in person. Currently right now, because of COVID, we're not. Everything we're doing again is via phone line or like Zoom, as we're doing. But we continue to find ways to help families. And even during this time, we've actually been actively calling all of our families, checking on them, because we find them isolated. The other piece of this is direct referrals. If you're working with patients and they are experiencing dementia, you're diagnosing or you're working with them, if you're just referring them on, that's great, to another physician. But if you're actually doing that, we're happy to connect with you and actually have a direct referral. And what that would allow you to do is, when you're talking to the patient, if you say, would you like someone from the Alzheimer's Association to call? If they give permission, that's a really big key. We find if we don't have permission, they're not real happy to always hear from us. And so anyway, but if you get permission, and then we have a simple link that we can work with you to have, or your staff to have, and it's HIPAA compliant. And so anyway, that's one of the things that we've been trying to build on, so we can grow the number of people getting helped as they're seeing their physicians, et cetera. Just real quick, I wanted to touch on, very quick highlight on this is we're moving into improving system work now and around long-term care. We've published and are now working on projects to put into place dementia care practice recommendations. This is around long-term care facilities particularly, and it's published data on best practices, and you see over on the left the person-centered care focus, and then all the different areas. And so that's a new area that we're working on. And then our newest, as a regional director, as well as a local director, we are doing health systems work now. We are working with VA up in Saginaw, and we made a connect in there. We're working with Lake Health, West Virginia University, and we're actually building connections into, because so many health systems are actually, have the primary care physician practices. They have a high percentage of them. We're working directly with them, but are open to look at how we can help physician practices better educate themselves through Project Echo, which is a online mentoring program, and or policy and process change around cognitive assessment, diagnosis, management, and care planning. And so really exciting work, because one of our areas is early detection. We, Dr. Patel was talking about where the research is leading. We will someday have some treatment, and when it comes, we will have to have quality diagnosis, and we need to treat it earlier and get better at it so that we can help people get to treatments when those come. So again, we're here 24/7. We love serving the families, and it's been amazing over the years to watch how many different families come to us, and so many similar symptoms, though, of what we can do to help them along the process. So that's just a quick overview. And if you ever need different information, my email is here, and you can contact me directly, or you have my cell phone, and you're welcome to reach out, and I will connect you to the staff, as well as our 24/7 helpline is always available. So I'll turn it back over to you.
Thank you so much, Eric. It's our privilege that you joined us today, and thank you so much for sharing all the community resources that are available. It's very encouraging. The disease is tough, but it's very encouraging to see the expert we have around, the physicians, most families with dedicated caregivers, but most importantly, the resources to help the patients, caregivers. And I'm impressed to see that you even have support system for the physicians. It's very hard for some of our nursing home physicians who see these patients day in and day out. Some have social support and some absolutely don't. And you become their heroes or angels or whatever. So it's beautiful that you are able to support all those involved. Thank you so much for joining us today. And thank you for sharing your information so people can reach out if they need help. So we will start our questions. We got a few people. Did you receive any questions, or should I go ahead? I got a couple that came through.
I have a few questions, but you can go ahead and then.
The first question came from Denise. Father had dementia. What are my chances?
Should I answer that?
Yes, please.
If somebody's father had dementia, we know from information we look at, currently we know there's a slightly higher risk, but it's not dramatic. And we are not at a phase where we try to test any family members who may be at risk of just because of family history. That alone is not enough. But maybe in another 5 or 10 years, it may change. So depending on the multiple other risk factors, there is some increased risk. Like I said, depending on, we don't routinely do the genetic testing, but in some cases, if someone is younger and they begin to have symptoms of memory problem and they have family history, then we may do the genetic test. So it's all based on case-by-case situation.
So any other comments from the panelists? So the next question is, how do you diagnose preclinical Alzheimer's dementia, and what can be done to prevent progression, if any?
At the present time, there is really no specific treatment in either the preclinical stage or in the MCI stage. We do not have any medication that can stop or slow the progression. The preclinical stage is more for research purposes. These are patients where they have been studying either because of family history or whatever, and studies of brains and spinal fluid on patients without any symptoms. And we know there are changes that happen for a long time before the patient becomes symptomatic. So we don't know who is going to have a preclinical situation. So really, and even if you do know, like there are certain situations where where patients come to us because of family history, they're concerned. And before we even subject them to genetic testing, it's like with any other genetic disorder, we want to make sure that they know why they want to get the test, that they're mentally competent, that this is not going to throw them into depression. This could change their lifestyle. It could change their future prospects of getting life insurance, or it could change their job situation. So multiple factors have to be considered. So we would refer them for genetic counseling before even doing the test sometimes.
So ApoE4 is being used in research, but again, it's not everybody with ApoE4 has Alzheimer's dementia. Not everybody without ApoE4 does not have it. So it's one of the things that they're looking at. But again, like Dr. Venkatesh said, it's not very clear at all. Primary care is doing these Medicare wellness visits where we are assessing cognitive function on a yearly basis, which is helping us pick up some people earlier than we would have maybe. So those are some of the things that we can do. Families can be more aware of the fact that perhaps people are misplacing things. The danger is like putting something on the stove and forgetting about it, causing a fire. Driving is a big thing, and I'll tell you, they forget a lot of things, but they don't forget the physician who took away the driver's license. And so that is something, but it's very important to be, to do that, because we do have a lot of accidents based on that.
So the most challenging thing, a question came through. How do you tell someone they have got dementia? Maybe Amita, you can, whoever wants to take it.
I think it's very important to be very honest with them so they have time to process and also to prepare. So we just tell them about the risk factor, that it's related to their age. These are the symptoms we are seeing, and we think that this is the most likely diagnosis. We give them really time to process this and ask them about how they feel about this diagnosis, and what are the next steps they want to take related to this. We ask them about their living will, ask them about plan, ask them about the support network that they have. What do they want to plan to do now that they know that they have this diagnosis? So just don't throw a diagnosis at them. Just ask them about how they are processing the diagnosis, what plan they are going to make about it, and plan to see them in a week, or plan to see them immediately. Make sure that somebody is with them when you tell them about this diagnosis, or at least they have some support system,
So from caregiver's point of view, I know you told us not to confront them. There will be, like they come to you as a physician, you told them what you think, but then most often the family members probably are not there, but now the family members have to reinforce the diagnosis. They're living with them every day.
I will tell them the diagnosis when somebody is, a family is in the room, because I try to explain to them. I would take a good 1 hour to explain what the diagnosis really means, what the long-term need, what they need to plan, what they need to do about the living will, the durable power of attorney, what they need to start doing as a family. So generally don't throw a diagnosis at them. Make sure, unless the patient is in a nursing home, it's a very different thing. Patient is at moderate or moderate to severe stage in a nursing home already, then it's a different. But if it's an office patient, it's an assisted living patient, you're doing this, you want to take the time, because then they have to process all this. make sure that you're telling them what the long-term needs for this patient are going to be, and is the family going to be available to do that? And if not, what alternative plans they are going to make for support for this person, and then help them identify what other resources are going to be available for them.
So some of the problems are that the families themselves are in denial, and a lot of children, so a lot of adult children try to ignore the diagnosis or ignore the symptoms, because that would mean that they would have to step up and
provide more
care, which is really the biggest challenge, because a lot of times families are like, oh, my mom is fine, my dad is fine, don't worry about it, they don't have any cognitive problems, when you know for sure that they do. So I think those are some of the challenges. I think Dr. Neravetla wants to make a comment.
Hey, thank you, guys. This was an excellent presentation. And applaud API for Miami Valley API, I should say, taking a lead on starting our sessions. Very meaningful, important disease problems we as Indians facing in our own families, as well as the patients we care for. So excellent presentation by Dr. Venkatesh and Dr. Patel. Amita, she highlighted how difficult, how resource intensive it is to take care of somebody in your family or friends who has dementia. And Meenakshi elaborated on how far behind we are any treatment options. So all we have is a support option. So the question begs, we need to pay more attention to prevention. So we had Eric on the line. You know, Alzheimer's Society says, if you have hypertension, your probability of getting Alzheimer's, dementia, goes up by 700%. Let me repeat that, 700%. So prevention of hypertension is in the core of prevention of what we now call multi-infarct dementia or vascular dementia, which is really the problem for most Indians, because almost all of them have high blood pressure and diabetes. So for them, this Lewy body dementia, which generally affects younger people, is not the main issue. Right? We really never know, because until you do an autopsy, you don't know that you got a Lewy body dementia, but we cannot do autopsy on anybody. So knowing the number of hypertensive, number of diabetes, number of atrial fibrillations, number of heart failures, all these are causes of multi-infarct dementia, and any number of them are actually preventable. So there are two, if you escape everything else in life, if you don't pay attention to prevention of hypertension, two of those things are most likely to hit us if we don't pay attention to hypertension, both prevention and treatment. One of them is dementia, and the second is heart failure. You cannot escape one or the other. I'm just kind of telling you based on what I see around, and my more than 12 years of research, and I've written, as many people know, a number of times on this subject. So let's make this as a focal point to work on prevention of hypertension. I hope the members who are listening will
it's actually great to talk about more preventative option, because this disease is just such a difficult one. And if we can even prevent 1%, that's great. So that's phenomenal. We are able to talk about preventative options. Dr. Rajshekhar also had a comment.
Yes, it was a nice discussion. Thank you very much. I couldn't agree more than I agree with Surendra Neravetla. Prevention, because especially the doctors have mentioned that no drugs have been approved, and by no means I'm an expert on this, but I'm passionately teaching nutrition. So based on my knowledge, it's all evidence-based. I'm just sharing that APO4. You talked about Meenakshi, but it has been shown that a lot of people, especially Indian, they think it's a genetics, but they have studied people taking bad diets like trans fats, and they selected few groups of people with the APO4 genes, and then they found out people who had healthy diets did not have early signs of dementia. So prevention again is there. It's the important thing. As Surendra mentioned, anything that decreases the blood flow to the brain, it causes. So basically, we talked about all the problems, and I couldn't agree. Like John says, it's a fearful disease. And I say that it's nothing worse than being healthy and not being able to recognize our loved ones. So it boils down to prevention. So the diet, the incident, and Mangala mentioned about amyloid proteins, and it's all again free radicals. So encourage people to eat antioxidants, fruits and vegetables. People are taking it very lightly. This is a dreadful disease. So diet, prevention, exercise. They have shown that BDNF factor, I'm sure you experts know that brain derivative neurotrophic factors increases if you do treadmill every, they've done studies. Again, this is all evidence-based. Every 40 minutes of treadmill has shown to increase the BDNF factors. And then it has shown that MRI scans have shown that the hippocampal volume is increased. So this is all boils down to prevention. I know, but we talk about preventing and reversible diseases, but when it comes to Alzheimer's, I think we have to emphasize more because this is worst disease anybody could have, okay? So that's what I just wanted to share. You covered most of the things, but people should be kind of forcing themselves, like TV watching. So the TV watching is most dangerous thing. So it will create all the negative emotions, and then you're not activating your brain cell. That is one thing. So it has been shown and proven that less than 3 hours a day is recommended. If I don't even watch that one. That is one thing. And then the sleep. People are not, if you have sleep deprived, they have been shown that the brain blood flow will be decreased. So adequate sleep recommended is 7 hours if possible. You know, that is one thing. So it boils down to prevention, especially when it comes to Alzheimer's. Especially when it comes to Alzheimer's, very dreadful disease. Eric mentioned about all the support system. And also, I'm not an insurance agent, but I think you all younger physicians should look into long-term care for health insurance coverage. I don't know if Eric agrees or not, but a lot of people don't understand that Medicare may not cover. So something to look into that. Maybe Eric, you guys can dig, but I'm not an agent or I'm not promoting anything, but that's what I'm on. I'm covered with long-term, but that's not, I'm not promoting or encouraging anything, but it's up to you all. It's a very dreadful disease. Thank you. It was a beautiful presentation, and it's all boils down to nutrition, staying healthy, being active.
Thank you so much. One other question. So I think this is just a comment that my mother, like that most family members would say, my mother would die of her disease, not from deliberate starvation and dehydration. That's how most people feel. So that's where the artificial feeding comes into play. So the concept of VSED, what is it? Voluntary stopping of eating and drinking. And I would like to hear from the panel individually what your thoughts on it. I think most families probably struggle on this, especially if they don't have a living will, health power of attorney, DNR status. So if you could help us understand, that will be great.
You know, this comes initially, one of the earlier questions was, how do we tell the patient? You know, you want the patient to be able to make a decision while they're still capable of making a decision. So initially you tell them about the disease. As it sinks in, you see them back. They gain more confidence. After a few visits, we start talking about healthcare power of it. Initially, it's more driving and those kind of lifestyle problems. And then before they get into more advanced stages, you want to talk to them. That's when you talk to them about the healthcare power of attorney and what they want, how aggressive do they want? Do they want G-tube and so on? Most of the time, you'd like to have the discussion while the patient is still capable of making the decision. So there is no guilt feeling on part of the family.
So yeah, we encourage people to eat, like in the nursing home is where you see this more often. But you don't really force feed anyone. And if they decide they're not going to eat or drink, and they have said that they don't want any artificial hydration or nutrition, it's okay. It's a normal way of going. In the animal kingdom, that's how pretty much everybody goes is to stop eating and drinking towards the end. It actually is a more comfortable way of going than trying to push fluids and push hydration. So I think as long as the person has thought it through and has made those decisions for themselves when they could make those decisions, and decision-making capacity is a whole different lecture in and of itself. But as long as they have done that, I think it's quite okay to follow their wishes, so to speak. And I just wanted to make a comment about the difference between multi-infarct dementia and Alzheimer's dementia. They're two different dementias. And I just wanted to ask Dr. Venkatesh what her thoughts were on that in terms of, separating the two.
Yes. What Dr. Neravetla brought up about the vascular etiologies, there's no question. Most of the time, depending on in fact, the routine MRI that we do on patients with dementia are going to have some white matter lesions, which we say, the way we explain to patients like mini strokes or it's hardening of the arteries, that's what we would call. And, to strictly say vascular dementia, you look for multiple infarcts, extensive vascular disease on the MRI. And quite often the two coexist. There is superimposed vascular situation on Alzheimer's. And the only way you're going to know this is at autopsy. And the way you treat the dementias would be the same at the present time. I mean, you treat the vascular risk factors, you treat their underlying dementia. But there is a lot of, the two coexist, maybe to different degrees. It's difficult to say this is purely only Alzheimer's, because many patients in their 80s are going to have lots of spots on their MRI when you obtain the study. So there's coexistence of the two.
Actually, there were two large studies, autopsy studies that were done that showed that there was an overlap of vascular dementia, Lewy body dementia, and Alzheimer's dementia in 49% of patients.
Yes. It's a very large number. And in fact, you cannot be, what you may think as in the past, the only way we used to say, the only way you could say for sure it was Alzheimer's was autopsy. It was always probable. You exclude other causes, you look at your clinical picture, you do the lab studies, imaging studies to rule out other etiologies, and by exclusion, you would say probable Alzheimer's. Now we have a little more definitive, you can do the PET scan, you can do, and some of the other testing that's done on experimental, in clinical research situations, not routinely, but the most definitive is only autopsy, and quite often there's a lot of overlap of different problems.
Eric, do you have any comments on that?
If I could actually back up to the prevention conversation, if people want to do further research, the Alzheimer's Association is actually funding what's called the US Pointer Study, based on the finger study that was done in Finland that found that there was impact to lifestyle changes. And so the Pointer study is taking on that. There's 4 areas trying to improve cardiovascular risk factors. So the hypertension area that was talked about and others, diet, exercise, and cognitive action. And so that is being studied now across. We've got centers open and that we're adding patients to. And so we're actually studying, it's a double-blind placebo study, so that we would actually have evidence on prevention if this works, and based on the work of the finger study. So if you want to look at that, it's called US Pointer, and it's actually really exciting. So the Alzheimer's Association is embracing, you saw that in our mission, as a big part of what we're doing. And we'll be looking forward. Not only did we fund that, but then we also worked and got additional funding from the National Institute of Aging to do scanning. So we're going to be able to do the PET scans to look at amyloid plaques and tangles to see if there's any evidence of change in the brain in doing that. So it's a very comprehensive study, and we're excited about that as an association to do that and push not only on the treatment side, which we work on as well, but also on the prevention side.
That's excellent.
I have a few questions. First question I have is for Eric. Uh, Thank you for giving wonderful information about caretaker resources. The one question I have, I treat Alzheimer's patients, and many times I see a lot of caretaker burnout. At micro level, what kind of services do you guys have? Do you guys have somebody who can go to patient's home, provide a little break to the patient, as family, so they can go out and take a little breather? Do you guys have a respite care information or any other resources you can provide, which I can tell my patients before even I talk about the support group?
Yeah. So one of the things that I would really suggest is the direct referral. And then what we will do is we'll sit down and talk with them. And we, for sure, one of the things we're really measuring is caregiver burnout. When we're talking to them, some people are just, sometimes we're on the other side of the diagnosis you all make, right? And so we're working with them on that. But sometimes they're into the process. They need respite, they won't listen sometimes, or if you're suggesting it. And so having time to talk through the disease, sometimes they still don't even understand the disease and what's next. And so I find that if I can help them understand the disease and what's next, and then one of the things I've done with caregivers in my own work with them is most of them are willing to die trying to care for their loved ones. So telling them they need a break actually just empowers them more to dig in their heels. So one of the things I suggest, or what I say to families is, listen, I know you want to provide care as long as you can. If you want to keep the person home longer, or if you want to, whatever your goal is, the very thing that will stop your goal is actually your well-being. And if they see their well-being as something that would stop them from their goal of this caregiving role, sometimes they'll listen a little bit more. So when we have those conversations, if you refer and we're able to do a care consultation with them, those are the kind of things, not only are we giving them support for respite, connecting them to funding if they don't have it to help get respite, use adult daycare, home health care. Sometimes they need to place, as we all know, the families are just on the edge and it's too much. But what we're trying to do is help them put a plan together, help them feel empowered to make that happen, and then get them to think about what they can do for themselves. But again, I've always tried to take it from the vantage point of, if your goal is to keep them home, if you get sick, you can't make your goal. So what can we do to help you? And so that's where we have to really try to address that burnout, because most of them are willing to burn out for the cause, because they want to be there for their families.
Thank you very much.
Sure.
The second question I have is for Dr. Amita Patel. When we see people, the patient with Alzheimer's dementia, they have behavior issues. And when we are ready to start antipsychotic, where there is a black box warning, where how do you approach the patient's family that, hey, this medication is going to help you with the quality, but how do you approach and what do you explain to them that would help patient's family to understand that that is probably appropriate choice?
Best is to explain the symptoms that you're trying to treat. First you have to explain the exact symptoms you're trying to treat, then explain the behavior interventions you have tried and failed, and then the risk it's posing to the patient or the caregivers, and explain to them that the behavior intervention did not help and why you have to use this medication, what benefit you're trying to get out of this medication, and explain the risk and benefit. That yes, there is a risk, but you're going to try and use it at the lowest possible dose for the shortest possible time, and then try to wean it off as soon as possible. But you have to use it for short term because the behavior is causing the risk and it's affecting their maximum level of functioning. That's the way I always pose it, that these are the behaviors that's happening. You've tried this behavior intervention that failed. This is the behavior that's causing this risk. And I'm going to use it for shortest possible time and try to then do gradual dosage reduction and then try to take them off as soon as possible.
So the actual risk and why this black box warning was there for the antipsychotics is the risk of stroke, and the risk of stroke increased from 3 per 1,000 to 4 per 1,000. So when you put that in perspective with the day-to-day behaviors, it becomes quite easy to make a decision in terms of helping the behaviors, as opposed to the risk of having a stroke 1 in 1,000 more than the normal.
And they do have other risk factors that do cause the stroke. So sometimes, you know, that makes them a little leery about it. So you just have to explain to them properly. And document it.
Anything else on that?
The black box warning doesn't prevent me from prescribing the medications. You know, like Amita said, you know, the risk, you look at the risk versus benefit, and there's no question the benefit far outweighs, but because it's expected, we are required to tell patients all the side effects.
Yes. And
Thank you.
document it.
Thank you.
So I'm hoping most of us here have their paperwork in place. Living well, health part of it. I mean, you know, I do.
Some are too young, but it's never too, you're never.
So don't get me wrong. I am also too young, but I still have my paperwork in place. So don't think I'm old. I'm not. No gray yet. That's all. But my question is, we have a lot of resources, but let's say if someone wants to start working on it, what are the resources available? So what is the first step?
Eric, you want to take this?
Yeah, I was trying to find my mute button. I would say education. So one of the education classes that we've had for years, we usually ask an attorney to speak on this issue, both on the cost side or the finance side, but also the living will and things like that. I think as families can understand and hear and listen, and then I think it takes it away from such an emotional decision to, okay, I understand why we're doing this. So we have found that to be extremely helpful. And then, you know, if people have resources to go ahead and contact attorney that, you know, sometimes can walk through those. Some of our attorneys that do this actually have a heart for helping the families, not just with the legal and financial aspect of the will and those things, but really helping the families understand this part, what happens, further decision making that they might want to add in, language and things like that. So getting a good, getting someone who knows and understands that. One of the other things that we try to share with families is to talk about it. So I have seen this over and over, that just because people have these documents doesn't mean they'll be honored in a hospital if no one knows about them. And so one of the things we suggest to families is to not only have them, but talk about them. So, you know, and there's no good time to bring this topic up, you know, Thanksgiving dinner or whatever, but it's never fun, but at some point you have to have a conversation. So we really encourage our families not to only do that, but sit down with their kids and actually go over what their wishes are, what they want. And having lived through that with actually my own father, you know, it just makes it so much simpler when everyone's talked about it and discussed it and know that they're there.
One of the things we did not talk about is the financial implication of caring for the Alzheimer's patient. And so it's very important to get an attorney involved early on to try to separate finances. Otherwise, the spouse is left with almost nothing to live by, because all the resources are used up in caring for the Alzheimer's patient. So it's very important to separate the finances to some extent to allow the spouse some ability to survive after that. It is pretty devastating, both emotionally and financially for the family. So that is something important. And I think Dr. Rajshekharan brought up the long-term care policy, which is also something to think about for the younger population.
Great. Dr. Saraswati Kalwakota has a comment.
Hello, all of you. Great speakers. Wonderful job. And I really enjoyed this whole step-by-step approach of this debilitating disease, Alzheimer's disease. And I exactly know what we are all talking. And there are a couple of things I would like to share. Like Dr. Kolipara mentioned about long-term care. It is a great idea, but how many people can afford is a question that in addition to your routine healthcare insurances and other things, starting healthcare at a young age has its low premiums, but that is a question we all have to ask ourselves to see how much we can afford long-term care. But when you have it, that's well and good. The other thing Dr. Narvetla mentioned about the preventable diseases, most of the times the prevention plays a major role, as we all have been talking about. However, how many people we really work on that right in the beginning itself? That is a question too. So we all have to be aware of that. The third thing I really like to mention is in our own community. It's like, you take care of your family first, you take care of your city first, you take care of your district, you take care of your country, state-wise, and like that. There are so many problems. This issue is a very long-term disease. This is something one family, one child, one's daughter is very difficult to hold it. So this isn't like a coronary artery disease or, it's like you or get out of it, that is totally different. And this, we have seen our own community members who have the disease, who just happen to go on the street and then get lost and come back. I think we have to really help our own community by coming up with something to see that the parents who are here already, not us, I mean, I have not come to that stage yet, maybe coming soon. So there are so many people who came to live with their children, and how much support they're having. I see a lot of times they're unhappy because they don't have a support system. And especially if they are sick like this, or sick from chronic illness, where some children cannot really take over all the responsibility. I think there should be somewhere a social frame has to be started to our community, where some, people should feel comfortable. Okay, if I don't have enough money, maybe I can take help from this Indian community. For our own, first, we take care of our own, then we expand our help to others. If I cannot take care of myself, I cannot take care of my family. So we have to come up with a stronger solution of not neglecting the people in the community who need help. Not everybody needs help. Not everybody needs help. So if we can slowly expand our needs and our commitment, I think that might give us some solution. That's all I wanted to share. Otherwise, the subject matter is done so well, and I really congratulate all of you.
Thank you. Great thoughts, something for us to continue to work on.
Yeah.
Any other questions or comments?
Sure, if I could touch on that quickly. One of the things we've been expanding on is a volunteer network to do more of our education, because we just can't reach we have 90,000 caregivers just in the Miami Valley. So, if there's someone here who would be interested, because I think going into your own community, taking the 10 warning signs talk, and going and having this conversation so that people who might be at the point where they've tried to take care of themselves within their family, they're feeling stuck, or they just need help, that can be offered. And so happy to work with anybody who might be interested to go out into your own community and actually share this, because it might be received better, have a support group that's focused just on this community. So we'd be very happy to talk to you all about that, to see what we could do to create something that's geared to whatever community that we can find, to whoever will listen. And so we find people you know, a lot of times hear from someone in their own community, even over us. So would love to do that. So I'll put my email in the chat box below if you'd like.
Sure.
Wonderful.
So, Eric, it would be great. I will probably email you through that, but it will be great if you can share that information of the voluntary services that we can forward to within our contacts through the community and see who is interested and willing to help others. So I think that will be great initiative. Any other comments? I think we are well over our time. Thank you so much for everybody for sticking around. I want to specifically thank Dr. Amulya Belgavi, who is the force behind putting this together, but she's working, she's not here. And also Dr. Meenakshi Patel, she is the one expert in this disease and mainly arranged this program, and Ashwin for always our IT support. I would let Dr. Meenakshi Patel say a few words now.
So thank you so much, everyone, for joining us this evening. I especially want to thank Dr. Venkatesh, Dr. Amita Patel, and Eric Van Leeman for quickly agreeing to speak at this session, even though I gave them very little time to respond. And of course, Amulya for helping me get all this organized, and Ashwin, our rock, who helps us with every IT issue that we have. Thank you so much. And what we would like also, and you can comment in the MVAPI section, is what topics would you like to hear about and what could we do better? I think both of those things would help us to develop programs that are more meaningful for you. So thank you very much, everyone.
Thank you guys for a very good job.
Thank you for coordinating.
Thank you.
Well,
Thank you all. Bye-bye. Have a
Bye-bye.
great Sunday evening.
Yes.